In this video, we show how a DIP arthrodesis is operated from distal with the shark screw allograft. If the arthrodesis of the DIP joint should be done in extended position, then the shark screw must be inserted distally via the fingertip. A Y-shaped skin incision is chosen for free access to the joint. The extensor apparatus is exposed, and the extensor tendon is cut diagonally at the base. This makes it easier to suture later. Then we cut the collateral ligaments. With maximum flexion in the DIP joint, we remove all exophytes with a luer. We then resect the trochlea with a luer or oscillating saw. If the two surfaces cannot be aligned after resection, the blocking bone remnants, which are usually palmar, must be removed with a luer. The sclerotic bone of the two DIP articular surfaces is freshened with the tip of a K-wire or thin drill. We take a 1.6 mm K-wire and push it centrally from the middle of the distal phalanx distally. The aim is to come out with the wire at the tip centrally under the fingernail. With the 1.6 mm K-wire, we drill a central canal into the shaft of the middle phalanx. Now we change to a 1.2 mm K-wire. From the joint, we push a 1.2 mm K-wire distally and thread the middle phalanx over the pre-drilled 1.6 mm channel. Now we check the position of the arthrodesis by intraoperative X-ray control. We make a prick incision at the exit point of the K-wire at the fingertip. Then we drill over the K-wire and cut the thread. The depth of the drill can be read from the laser markings. The shark screw to be inserted should protrude about 1.5 centimeters above the arthrodesis gap. We place the drill on the finger and estimate how deep the drill has to go under the skin to bridge the arthrodesis gap by 1.5 centimeters. In this case, we have to sink the drill between 3 and 3.5 centimeters to achieve the desired depth. Since we almost exclusively use a shark screw cut with a diameter of 3.5 millimeters for the DIP arthrodesis, we drill the core hole with the blue drill over the K-wire. Then we cut the thread with the blue tap using a drill. We can see the desired drilling depth from the laser markings on the side. It is important to cut the thread slowly and without pressure, and at most as deep as was previously drilled. With index finger and thumb, the position of the two links can be held well. Afterwards, we rinse the canal with physiological saline solution so that the fine bone chips do not block when screwing in the shark screw. When inserting the shark screw, we make sure that the position of the two bone fragments is maintained and that the screw is inserted without pressure. We saw off the protruding material of the screw with an oscillating saw just above the bone surface. We push the skin back as far as possible with the saw blade and create a predetermined breaking point through the cut on the screw. We then use a lyre to break away the screw protrusion. The postoperative treatment can vary from patient to patient, but in most cases, a short plaster splint or Stark's splint is recommended for 4 weeks. The operated finger should not be loaded for another 2 weeks. Support through occupational